And I am going to share my screen. And I think we're set. Okay, Sarah, I'll start whenever you're ready, or when you want me to.
Dr. Chinn, we're live and recording.
Okay, is that my cue? I'm on?
Yes, you're on.
Okay. All righty. Well, for those of you who don't know who I am, my name is Steve Chinn. I'm a Joint Commission resource consultant. And then my main job is I'm a clinical associate professor in the Department of Medicine at the Stanford School of Medicine. We're here today to speak about a concept that's kind of near to dear my heart. It's known as what can we do to reduce errors, medical errors specifically, how it's tied to patient safety, and how does culture of safety and psychological safety plays into this picture. So a little bit about my background. As I said, I'm a podiatrist, or maybe I didn't say, I'm a podiatrist by background, practiced for a number of years, and then about 25 years ago got into hospital administration. Also got recruited by Joint Commission and became a surveyor for them in multiple programs. I've been a chief quality executive in the Kaiser system, the VA system, worked in community hospital, freestanding psychiatric facility, and then pretty much the last 12 years I've been the accreditation regulatory officer and also patient safety officer for several years at Stanford Healthcare, part of Stanford Medicine. So glad to join you. And what we're going to do, oh, by the way, that's during the pandemic, when we all had to wear masks all the time. So that's me with a mask in case you see me running around with a mask, or me without a mask in case you see me running around without a mask. So our objective of today's program is really talk a little bit about the relationship between medical error and patient safety, and more specifically, culture of safety, and this describe how psychological safety plays into teamwork. Now, many of us, are considered to be bosses and leaders for our individual unit, our clinic, our practice, our department, our institution, organization. And I love this little graphic because one of the things I do at Stanford, I'm part of the physician leadership program, as well as the General Management Leadership Academy. And so I do a fair amount of instruction on leadership, teamwork, communications, and team dynamics. And one of the things about being a leader is trying to get the group to work together to achieve the goals, versus bosses have the tendency to be able to bark the order out, but not necessarily set the mission, vision, and goals of an organization. So many of you folks who may be dialed in on this program, you may be in that role of, your clinic, leader, practice leader, you may be a department leader, a division leader, a chief of a service, a senior leader of the organization, whatever the case is. You as a leader has a responsibility of making sure that everybody on the team knows what the mission is to be able to carry it out. Now, when we're talking about teamwork, it makes me think, and I'm in the San Francisco Bay Area, and I can't give a lot of detail, but a number of these guys may or may not have been treated by my organization. And so when I think of teamwork, I think of these three, plus the fourth guy, who's in the background, Andre Iguodala, who at one point in his career did a stint with you folks in the Philadelphia area. Makes me think of teamwork. And why I think of good teamwork is that everyone's on the same page, carrying out a specific part of their duty and responsibility. And so, naturally, when all three of them are in sync and working together on the same page with Andre, typically working off of the bench, you usually get pretty doggone good results. So I love that example as teamwork. Now, compare that to you folks, who are in the operating room. Do you have the same environment? And this is actually a photo of the cardiovascular team at my institution, busy, doing a cardiac procedure, heart transplant. And so naturally you got a number of folks in that room trying to carry out the mission, the surgeon, super key, assistant, scrub tech, perfusionist. Certainly in the case of orthopedics, you have many times you have manufacturer reps, the vendors in there provide technical expertise. And that's not counting your anesthesia team, to be able to provide the anesthesia so you could do the procedure. So when the team is on the same page, communicating well, raising issues up, addressing things on a real-time basis, it creates a pretty fun environment to get the work done. Intense, but yet productive. And so that's part of what we want to get into in terms of how the team operates. And when it doesn't operate, it leads to potentially issues or outcomes that may not be desirable. Now, here's another team, that's on the lower left-hand corner, and they're actually in a conference room. And this is actually a meeting where they are actually doing some improvement work. I could tell this one particular group because they love they love their lunches and they love their food, their snacks. You can see the desserts in the front there, and then they also love their coffee. And so this is an administrative management team that's doing some improvement in the conference room. And it's the same concept we talk about on the clinical side, where, in the clinical world, you're busy taking care of a patient, trying to save their life or improve their life. A administrative team is trying to keep the operation going or trying to make it run better, which we know in healthcare today is super complex, just like it is in healthcare. Now, we're here to talk about medical errors. And I want to share some statistics with you on why we're even raising this issue. You've probably seen this USA Today news. Actually, it was published USA Today, Wall Street Journal, New York Times. Dr. Makari, surgeon at Johns Hopkins, actually him and his associate, Mr. Daniel, actually published a study in 2016, and they looked at data from 2013, and based on the CDC, top causes of death in 2013, it looked like medical error. They attributed almost over 250,000 deaths might have been attributed to medical error based on their study. Now, many of you might be familiar with the 1998 Institute of Medicine report that actually said a version of the same exact thing, except they estimated it was anywhere from 49 to 98,000 deaths were attributed to medical error. So clearly, all the work we've been doing over the last 20 years, based on some of these estimates and statistical analysis, says we got a huge issue. And 1/3 in 2013, the deaths might have been attributed to medical errors. And so, of course, with COVID, in 2020, I think it was over 275,000, maybe about 300,000 deaths in 2020. So it would have been the third highest, but nevertheless, it kind of puts a statement that says, right behind heart disease and cancer is medical errors. But it's so interesting that, for the most part, we don't hear nearly the same kind of news as some of these other incidents and events that actually contributes to deaths in the United States. So that kind of raises the issue about healthcare as an industry in terms of how safe it is. And if you look at this particular graphic, on the far left side, we have dangerous, industries. And then on the far right side, we have ultra safe industry. And so when you think of super dangerous activities, certainly mountaineering and bungee jumping has a pretty significant number of fatalities per encounters or per intervention or per activity. Those are pretty risky. And of course, on the safe side, interesting enough, you have scheduled commercial airlines, European Railway, nuclear power, and theme parks. Theme parks are considered somewhat risky. Not if if you keep your both feet on the ground, you're in good shape. But once you get on some of those rides, we know bad things can happen. Now, what's in that middle category? Chemical manufacturing, chartered flights, and driving in the U.S. And I think driving. I'm in the San Francisco Bay Area. I think driving in the San Francisco Bay Area might be even riskier, just based on the nature of the way people drive. So you're thinking it's like, well, those are considered risky areas, risky industry, or risky activity. Where's healthcare? Ooh, basically one fatality for actually 6 admissions or 6 encounters could put it in the very, very dangerous. So healthcare isn't necessarily one of the safest industry based on data that's been collected. So this kind of led to an entity known as the Joint Commission. And the Joint Commission focused over the last 12 years, 13 years, with the former CEO, Dr. Chasson. They came up with this model of high reliability that was adapted in other industries, such as commercial airlines, nuclear power plants, some of the theme parks, they have adopted it, and then flight deck of the aircraft carriers, where these are industries where if something bad happened, it's catastrophic. People die. It may not be just one person. It could be multiple people who die from these bad events. And so one of the concepts that Dr. Chasson brought on board that's been promoted by Joint Commission, and the reason why your organization even considering Joint Commission, is that Joint Commission offers standards or structures, system, and process to get more reliable and consistent outcome. If we look at the data we just talked about, we would have to say, whoa, healthcare is not really safe. Will Joint Commission help us? The answer is yes, if you comply with the structure, system, processes that Joint Commission outlined. And one key component, because if you look at the 3 components it advocates, is leadership, safety culture, robust process improvement. Safety culture is actually key, because if you don't have staff speaking up and telling you something might not be right or something is missing, you might miss an opportunity to stop a bad thing from happening. It's really significant from a safety culture standpoint that people feel comfortable raising the issue up. Otherwise, what happens? And we have plenty of studies that show, especially in the operating room, that a couple of studies that I've looked at actually have said there has been one person in the room that knew that there was a miscount or something not right, but because the culture of the operating room, i.e., culture of the surgical team, culture of the anesthesia team, nursing team, they did not want to raise the issue for fear of getting verbally pummeled or verbally beaten up. And so that's why we're talking about this whole topic, because we find in our experience of doing root cause analysis, event review, that a good number of times bad things happen because we are missing the teamwork piece, or our communication is just not crystal clear. I love this little cartoon, and that is why we lift on 3. So, naturally they're talking about who's on the floor. So this kind of leads to the question. Okay, this kind of leads to the question. Is there a question? Does someone have a question?
This is a new patient candidate.
Oh, I did print out his thing.
All righty. So if you don't have a question, if you don't mind going on mute, that'd be great. We can hear everything. All right, perfect. So this leads to the question of what is patient safety, and some of you may know Dennis Quaid, and his story going back to 2009. He and his wife at the time had twins at a very well-known Los Angeles area hospital. Unfortunately, during the course of his twins' hospitalization, they received concentrated heparin instead of the heparin flush solution. I think it's 100 time? Yeah, 100 time concentration for the concentrated heparin. And as a result, when you give little babies concentrated heparin, that's really a bad day if it wasn't part of their treatment plan. And so he early on been on a push to advocate for safety measures in healthcare, healthcare system. Now, we're talking about medication, which is probably the one single intervention we do the most of, but that doesn't take us off the hook, for us in the surgical procedural side, because, we've had plenty of study, and the most, one study I can think of is the group from Minnesota that actually studies surgical events. They determined that based on their data, there's probably 50 wrong patient, wrong site, wrong procedure surgeries done across the United States on a weekly basis. 50 cases. Now, 50 in the whole scheme of things, you're probably saying, well, that's not a big deal. But if it was you or your family member or your best friend that got the wrong knee operated on, or ended up having the wrong kidney resected, you'd be pretty upset. And so, needless to say, from a patient safety standpoint, we're really focused on what is the process, what's the system, what are the challenges going on, what's the communication. As recent as a couple of weeks ago, I was actually doing a consultation in the Pennsylvania, Philadelphia area. And we were in the operating room. The orthopedist was actually paused to do the timeout like we were planned. And the nurse opened the conversation by saying, we're operating on the right knee. Everyone in the room froze, because everything on the x-ray, the template, the consent form, including the anesthesiologist, the circuit nurse, and the area that's prepped, you knew it wasn't the knee. If you're looking at what was prepped and draped, it was the hip. And the nurse pauses and goes, oh, my bad. That's why we do the timeout. We want to make sure everyone's on the same page. She actually made an honest mistake. She thought they were working on the knee. And there was some handoff, and she was running around trying to get things done. And so there was a little confusion. But ultimately, that's the reason why they have the requirement to do the timeout. And it's nothing more than a pause to verify we're working at the right place at the right time, doing the right procedure. Now, some of you know the story about Jessica Centellium, who was a 17-year-old teenager. And this goes back to 2008, 2009. She was a heart-lung transplant candidate at an academic medical center that, for whatever reason, the communication about the ABO compatibility between the donor and her was never communicated or miscommunicated or misunderstood. They ended up transplanting the incompatible organ into her, and subsequently she had a rejection, second surgery. She didn't survive that. Subsequently, she passed away. These are not patient safety events, okay? It's not safe. Bad things happen. And so the key thing to be cognizant of is that nobody wakes up in the morning coming into any of your practices, your clinic, your surgery center, your hospital, thinking they're going to make a mix-up or have a mistake or make an error or kill somebody. So what we found is that some of the common root causes is associated with these four things: poor communication or lack of communication, human factors, which is a whole science of itself. It's basically how the human being interacts with their environment. Leadership, you're thinking leadership, how's leadership? Well, leadership sets a culture of every unit, department, clinic, team. And if you have great culture, more time than not, you do great things. If you don't have good culture, sometimes you'll never know how bad things are because no one says anything, or you just have bad things happen. And that's where we're actually going to focus in for the next couple of minutes, because culture, safety culture, and the ability to have staff speak up is so key in this process. So I'm sure none of you have ever had this experience where someone was, barking down your throat, chewing you out for something you did. I've had my share of that experience as receiving that either as a podiatry student or as a resident. Didn't happen often, but I've seen it done to other folks, and it's embarrassing, right? It's embarrassing. I mean, once you have that kind of experience, what's the likelihood of you ever raising an issue up with that attending or that colleague, knowing that they will go nuclear in a minute? And some people will say, well, hey, this is, only a guy thing. We've also had, women do the same thing. And so naturally, when you have that kind of environment, what kind of a culture are you establishing if you have a tendency to go nuclear and react with people when they bring bad news to you, on a Friday afternoon at 4:30 before a 3-day weekend? Guaranteed, they'll never bring anything to you. And so that's how we miss out on opportunities of addressing things before bad things happen. So that kind of leads to the concept of psychological safety. And psychological safety, as you look at the slide here, it actually came from Amy Edmondson at Harvard. It's a belief that you won't be punished or humiliated for speaking up with ideas, questions, and concerns. It's a shared belief held by members of a team that others on the team will not embarrass, reject, or punish you for speaking up. One of my best example, and I was a resident when this happened. Some of you remember 1986 and the Challenger explosion. I think it was in February of that year, and I'm in California, so I happened to be on call, happened to turn the television on, in the room, as I was getting ready to go out and make rounds, and then I'm watching this thing happen. And you would think NASA, which turned out to be issue of the O-ring, they knew about it before the launch. Engineering tried to bring it up, but because they were so mission driven to launch, they blew off the engineers, and so they never heard about the fact there was a problem with the O-ring. As a result, we had a bunch of astronauts died in that explosion. Fast track that, speed it up. I think it was in 2003, we had the Columbia, and a version of the same thing, except in this case, it was foam chunks that were frozen that broke off of the main body of the shuttle and punctured a hole on the leading edge of that right wing of the shuttle. And as a result, when they came in re-entry, bad things happened. Clearly, the environment at the time, because they were so mission-driven, folks didn't feel it was safe to raise the issue because they've been chewed out, or they were neglected or ignored. So some of the benefits of psychological safety to think about. And these are all things that Joint Commission is advocating for, under the concept of safety culture, is that when you have psychological safety, you have better communication, you have an opportunity to fix things before bad things happen. You actually have an opportunity for better teamwork, coordination, and actually, ultimately, it comes down to better outcome, better care. One of the things about psychological safety, and we're, a couple of us are actually looking at some of this from the standpoint of burnout and well-being, of how lack of psychological safety does contribute to burnout. So, connect the dots. Is it a factor? Potentially. Is it the only thing that's causing burnout? No, absolutely not. But if you don't have a good environment where you don't feel like you're part of a team or can communicate, or you're fearful of making a misstep for just trying to do your job, that could contribute to burnout. So that kind of leads to Amy Edmondson, and you all may check this out. She's written a number of books on this concept. You can actually YouTube, and she does a number of presentations. She's an outstanding speaker, and her concepts makes total sense because part of her work was actually evaluating how teams worked in critical care. I think it was a pediatric critical care that she had actually done some of her initial work to look at the concept of culture and psychological safety as part of trying to improve outcome. The other gentleman we want to talk about is Ed Chinn, who's a MIT professor. I think, at this point, I think he's pretty much retired. I met Ed a couple years ago, 3 years ago. He actually came out of Stanford. His son actually does some work with Stanford. And he's another individual that you may want to check out because he's really focused on, culture as being an important part of leadership and making changes in organization for the better. So between Amy and Ed, you may want to check out some of their publication and some of their YouTube clips, presentation they've done over the years, because it comes down to this. If you don't have good communication, the sender of the message is expecting a certain outcome. And if the recipient of that message doesn't get the message clearly, they're going to carry out their task based on what they understand. And then, this particular slide tells you all the complexity that goes into sending a message and all the noise and barriers that can affect the nature of how the message is received, message decoded, actions implemented, and then how it gets back to the sender of the message. So what's the bottom line? And it comes down to some things like team etiquette. How do you interact with folks? How do you react to bad news? How do you respond to things? A lot of it, in terms of culture, is reflected on our behavior, and our behavior is reflected based on how we communicate with each other. And so I'm hopeful that, when you are working with your team, especially in an intense, high-risk, problem-prone situation, you give them an opportunity to speak, you listen to them actively, and that you don't react. Even though your first response is to explode and go nuclear, by doing that, you could establish a unsafe environment inadvertently without even realizing it, so that the next time they come up with something or they need to suggest something, they don't feel fearful of raising it to your attention. And so that way you can actually prevent bad things from happening. I can tell you from my own experience, having been at the sharp end of the process or participating in reviewing a process, it's not uncommon that we're in the middle, of doing a procedure, the complex technical part, or some issue or problem comes up. We're so focused on what we're trying to accomplish and do, we don't always hear what's going on around us, or we don't hear the suggestions that might be coming from, our assistant or the resident or the fellow. You just don't hear it. And so the key thing to recognize that, healthcare is a team sport. Everybody has a role and responsibility. Ultimately, you as the surgeon, proceduralist are ultimately responsible for it, but you do rely on your team to contribute information when it's critical. And you would rather hear that there's an issue as early as possible, rather than waiting until you get served papers to say you're getting sued for a complication that happened, 6 months ago, that you could have resolved back then if you knew it happened back then. So the suggestions on the slide are only some of the team etiquette things we do for some teamwork training, and there's just some concept that you may want to consider, when you're working with your team. Apply the PI. That's positive, instructional, and encouragement. Some of you may say, well, hey, this is all the, feel good, nice stuff, be nice to everybody. And it's like, well, that's part of it. But sometimes when you're giving instruction, you're trying to improve things so that you get a better outcome. And it's sometimes doing it in a positive way rather than in a punitive, abrasive, abusive way might get you a better result than if you did it the other way that I was just describing. A couple resources for you regarding teamwork, psychological safety, and then interprofessional communication. And then a little quote from Simon, I can never pronounce his name, Simon Sinek. And those of you who are dialed in, inevitably you're a leader in your organization, in your clinic, in your practice, with your patients, with your team. Leadership is not a license to do less. Leadership is a responsibility to do more. And I think with that, we'll open up for questions. We have roughly 11, 12 minutes. So at this point, Sarah, we're going to open up the question for anyone who might have dialed in on the program.
I don't have any questions, but I have a comment. This was a great presentation. Thank you. Very informative.
Thanks, Michelle. Thank you. We have a saying in quality patient safety accreditation. A lot of the adverse event and things we come across, we can't make this stuff up. We don't have to make it up. Bad things happen to patients all the time. And so, some of the stories that we have, they're real stories. I mean, I've done everything from helping the staff take a patient who not accidentally, they intentionally hung themselves. So I had to help take this, the individual off the fixture. So to wrong site surgery, retained foreign objects, significant medication error. Medication error. We do a lot of work with medication. And the reason why we try to minimize verbal order is that there's a likelihood of somebody misunderstanding. And one event that I reviewed where the nurse was pretty sure that the doctor said, a particular number, but did not understand that the doctor was referring to kilograms. And so they actually calculated based on pounds, and as a result gave the patient whatever the multiplier is 1.7 amount of the dose, and subsequently killed the patient. Now, the doctor said, I was pretty crystal clear on what I gave, and the nurse said they were pretty crystal clear on what they were told. But you know what? When you try to do things, verbally, is there a possibility of miscommunicating? That's exactly what happened in that particular situation. So like I said, people don't come into the practice in the morning or the hospital or surgery center in the morning thinking they're going to mess up. Bad things happen because we got system and processes that are maybe quite variable. Any other questions? Comments?
Yeah, this was a very good presentation. Thank you so much.
Oh, you're welcome. And Sarah has it recorded, so hopefully you can get an opportunity to share it. It's not super long. We did it within 30 minutes, so maybe you could post it on your internal website, and people will dial in and watch it as they're waiting for their room to turn over for their next case. How's that?
Thank you so much, Dr. Chinn.
All righty. Well, I think at this point, if there aren't any comments or questions, we'll go ahead and I'm going to stop sharing, and then folks can drop off. Although those of us who are staying on for the continuation of the JCR visit, we'll just stay on.